All right, today we're going to talk about a topic that's been on my mind for quite some time. It's a topic that comes up frequently when we're talking at the fire station, when I've done police training as well. So in a broad sense, we're going to talk about difficult calls, difficult interactions with patients, and difficult interactions with patients within the system, and what the different pieces of that system are, and why we have such frustrations. Most of us would agree that we went into what we're doing to help people. Most of the time when we act with either patients or a suspect, and again, sometimes they're both, sometimes they're one or the other. Sometimes it's not entirely clear when you show up on the call which one we're dealing with. But most of the time when we show up for that, whatever the 911 call is, or whatever the call for service is, most of the time we work to a reasonable solution, right? We make somebody's life better. We improve the problem that was going on in some way. That's kind of how we're wired, right? The calls that we're talking about, and I'm not going to go into any specific ones that we've talked about, but we remember these because they stick in your head. Even months or years later, I've talked to police and fire both who remember a call when this thing seemed to go sideways and there was not a good end to whatever was happening, right? We didn't feel good about it. At the end of the day, there was some solution or resolution, but it didn't feel good. Like often when we show up, we want it to be a win-win scenario. When I meet a patient in the ER, I have about 30 seconds in which they need to like me, because that visit has to go forward with some level of amicability. We have to get along. They don't have to really like me, but they can't hate me out of the gate. If they're completely unhappy with my attitude or what I say in those opening 30 seconds, the whole visit often goes completely sideways. So very quickly, I have to walk in and we have to be on the same page about what's going on. Acknowledging your frustration with being there, your long wait time, your frustration with the system, the medical problem you're dealing with. That has to happen fairly quickly. But again, the goal at the end of it is a win-win, that I feel like I did some good and the patient feels like some good was done for them, right? It's the same way when you go to 911 calls. We hope that there's some good resolution to this, that you're now better off than you were, and we can leave the call and go back to the police station or the fire station feeling like we did some good. We made this thing better, right? So my whiteboard is pretty busy today. We're going to start over on the left side and work across to the right and then come back down here. And I hope I can make sense of this for you and put my thoughts in a coherent way. So to start with, right, we're in the service industry. And I don't mean that as in the hospitality industry. That's a different thing. The hospitality industry is restaurants and hotels. We are in the service industry. It's in our name. So EMS, the S stands for services, right? The fire, we talk about being in the fire service. Service is in the name. Police departments often use the logo protect, or not the logo, but the catchphrase to protect and serve. Sometimes it's even on squad cars of some departments, right? So we serve. That's what we do. We're out in the world trying to make people better, make life better for people. It's service, service, serve, right? So with that in mind, it's important to keep in mind that it's not about you, right? So I'm going to come back to this at the end, but what you have going on in your personal life doesn't need to come to the call with you, right? And that's not to say that you never talk about your personal life at home, but talking to thousands of patients over the years in the ER, I can tell you that everybody has issues. You all know this. You all have issues in your own life, whether it's financial issues, relationship issues, sick relatives, sick kids, you're sick yourself, you have ailing parents, you have stressors about a divorce, you have stressors about custody. This is universal. Everybody has their stuff. Ideally, we also have a family here. So at the police station with your partners that are on shift with you, you can talk about it. At the fire station, around the dining room table, you can talk about it. In the kitchen, you can talk about it. That's perfectly healthy, right? But you also have issues at work because you have relationship issues with a subordinate. You have relationship issues with a supervisor. You don't get along with somebody on your shift. Human beings are complicated, complex. Complicated is a different thing. These are complex problems we're dealing with. Complicated problems can be solved with more math and more computing power. Humans are not that way. Humans are complex in all of the things that we have to deal with. So I'm not saying that you don't talk about personal issues at work. That doesn't make any sense. Your family at home and you have a family at work. You have the people you work with. Hopefully you can sort through your own issues and you have community that you can talk to about that. Right? Having people in your life that you can tell a story to about what's going on, they can help set you straight, whether you should just suck it up, that's not really a big deal, or I'm really sorry you're dealing with that thing. Oh, I have the same thing going on because my kid had the same issue when they were in school, and in sports, this thing was going on and it didn't turn out well, right? There's value in that. So talking is thinking, writing is thinking. Me doing this has helped me clarify my thoughts on this. So certainly bring your baggage to work in the sense that you can talk to your coworkers about it, and hopefully they help you. Hopefully you are a family and you have some people close enough to you at work that helps with that. However, that's very different than bringing that to the patient's bedside. When I go talk to patients in the ER, maybe I didn't sleep well for whatever reason during the day, and now I have to go back to my shift, and I'm super tired and I need a lot more caffeine, right? The patient doesn't need to know that. They don't care that I took my dog to the emergency vet in the middle of the day because my dog has an ear infection, right? That's not part of my story with the patient. I can't justify my behavior. Hey, I'm going to do a crappy job today because I'm really tired because my dog had an issue and she's got this ear infection going on. It's been a big complicated mess. Right? Patients don't care. It's not appropriate for me to share that with patients. So whatever your baggage is that you're dealing with, whether it's at work or at home, have people in your life that you can sort it out with. The patient is not the person to sort that out with. So bringing our personal stuff to the patient, to the bedside, that's not what we do, right? So solve that stuff somewhere else. You're gonna have to compartmentalize a little bit. I realize that going to work shortly after you had some disaster in your life, a loved one that died, somebody who's sick, up all night with a sick kid, we've all done that, right? But you have to compartmentalize that enough when we're dealing with patients. We still have a job to do. And again, it's about service, right? It's not about you. So we also have policy, procedure, and protocol that we fall under. We do things by the book. We have ethical, moral, and legal constraints around what we do. And I realize that this is not the same for patients. We're going to talk about what their thinking is on the world, which is different than ours, right? We fall under both of these things. You can summarize these two things, policy, procedure, protocol, ethical, moral, and legal constraints, as broadly doing the right thing. And the right thing has all these components to it, right? So that's what we're in the business of doing. The right thing, the best thing for the patient, whatever's medically indicated to do, however we can best help them solve that problem within the limitations that we have, right? A side note about police in particular, we don't want to cause what's referred to as officer-created jeopardy or officer-created injury or harm. As an example, let's say you have a veteran with PTSD. They have 6 combat deployments. They're not doing well when they get home. A loved one calls 911 because they're concerned about this person. There's no exigent circumstances. There's been no threats of suicide, but they talk to this person and the person sounds really sad on the phone, and we know the person has guns in their house and we know they're drinking, right? Police are not kicking down the door, barring exigent circumstances, to just go in that person's house and drag them to the hospital for their mental health issues, right? If there's no crime committed, police can't just kick in the door. You have to have the elements of a crime or exigent circumstances to do something like that. So we're not doing that. In the same way, when we put patients on a hold, it's a big deal. Most of the time when we put patients on a hold, things go fairly well. However, just recently I saw some body cam of, I believe it was Rochester, Minnesota. Officers put a patient, they thought he needed to be on a mental health hold. He didn't want to go. There's a scuffle in the kitchen and it turned into an officer-involved shooting. Right? I don't know the outcome of it, but it's not great for anybody, right? Those officers' lives are severely changed. If the person died, that's a tragedy, right? We wish that would never happen, but it does, right? So putting people on a hold, once we decide to go hands-on, and when we do it under the right circumstances, right? So they have to have the 3 pieces of this, which we've talked about many times, but you need to be a danger to yourself or others. You need to be mentally incapacitated or intoxicated. So essentially not coherent enough to be making good decisions for yourself. And there has to be some exigency, like just not taking your meds. You live in a group home and you have seizures and you're not taking your meds for 2 days. You could have a seizure, that's true. But there's plenty of people in the world who don't take their seizure meds, so there's not really any emergency to that. So putting that patient on a hold, maybe not so much. Once they have had a seizure, that changes things. They clearly are now a danger to themselves because they had a seizure, right? So my point about holds is that we need to take those seriously. We need to make sure that we are doing all of these things, following procedure and protocol, documenting the pieces of it that we believe makes them worthy to be on a hold. We're going to take their rights away, take them to the ER for further evaluation. And every time you lay hands on somebody, you don't know how it's going to end. Most of the time, we can restrain people enough. We can convince them to go to the ER. Most of the time, things go okay. But every now and then, it doesn't go okay. And sometimes when it doesn't go okay, it really doesn't go okay. So you end up with a tragedy like I just talked about. So it's not a small thing to put people on a hold and make matters worse. If there's another solution that we can work out, sometimes that's better. So, all right, so we'll come back to that at the end. The patient or the suspect, and sometimes they're both. Sometimes the individual we're dealing with may be one or the other. Again, when you get to the call, you maybe don't know what you're dealing with. So, two important points. There's a number of points here, and I'm probably missing some with all of these things. I'm probably missing some details, but I would say I've said this before. The patient gets a vote, and we'll talk about why that's the case. But they get to say what happens, which hospital they want to go to within reason. Right? We're not going to take somebody to St. Cloud, but within reason, they get a vote. They get some say in their care. If they're coherent enough to talk about their care, they often get to pick where they want to go. As an example, obviously we have STEMIs that go certain places, we have trauma that goes certain places, but the patient gets a vote in terms of what happens to them. If they don't want an IV and they're coherent, we don't always put an IV in everybody, even if we think they maybe need one, right? They also hold the trump card. So they sort of get the final say in this. And again, this gets into, when they have that, this gets into the fact that we feel like we're being played, we feel like we're betrayed, we feel like this doesn't make any sense because the patient's not doing what we believe to be in their best interest. They have different things in mind. So we can't assault people and put an IV in them for somebody who doesn't want an IV. So patients like this often have no or little thought of the consequences. Their immediate needs and wants are what's foremost in their mind. They're not thinking about tomorrow. They're not thinking about next week. They're not thinking about next month, next year. Often these folks have a relatively disordered life at baseline, and they often don't live in the world of my actions now and how that's going to affect me down the road, right? Which leads to just a spiral down often if you're not thinking about what your future self, the implications and the ramifications for your future self, right? They're certainly probably not thinking about what your job entails down the road or where this thing is going to end. They have their immediate wants and needs. If it's 20 below and I'm homeless, I might have chest pain, right? The ER is a better option for me than freezing to death, right? It doesn't justify, I'm not trying to justify patients who abuse and use the system inappropriately. But if we can have some empathy for folks who their only concern is not dying, right? And they will do whatever it takes to not freeze to death. So that might be chest pain every night for an entire week when it's a string of 20 below and they don't have any place to go. So these patients also often have mental health issues, chemical dependency issues, which complicate the picture. Either they're actively using, or they're in withdrawal, or they want to be using, right? Their mental health issues. There's a myriad of mental health issues. Maybe they need their meds. Maybe they need their meds adjusted. Maybe they're on too many meds, right? These are all confounders that impair their thought process frequently. Again, if they're homeless, that plays into a lot of these patients. Sometimes there's a criminal thing, and civil is maybe not the perfect word to use in EMS, but my point is we have to have, for the police to take somebody to jail, they have to have elements of a crime, right? And there's terms like reasonable suspicion or probable cause, right? And I'm not going to get into the weeds of that, but there have to be pieces of an actual crime before somebody can just go to jail. Behavior that we all understand to be inherently bad behavior does not always rise to the level of a crime that requires going to jail. Maybe it's a ticket, like for disorderly conduct. Maybe, again, there's misdemeanor, there's gross misdemeanor, there's felony, right? So depending on what we're dealing with, we would all agree it's maybe bad behavior, but if it's not criminal, the police can't just take people to jail for bad behavior. There needs to be a crime involved, right? Patients often have a perceived benefit of what they will get when they go to the ER. So for example, I have plenty of patients who come to the ER after an outburst at their group home. They fought with staff, they smashed a window, they were unhappy because another resident of the group home made them mad for whatever reason, right? I can tell you that I only work nights in the ER, and I can tell you that I've never gotten a patient out of a group home who came to the ER in the middle of the night, hates their group home, and wants to go to another group home. I don't have the resources. I don't have the people involved that make those decisions. I don't have the logistics available to me. I don't have a way to get you from one group home that you hate to another group home, not in the middle of the night. It doesn't happen. Add the weekend into that, there's only daytime hours, Monday through Friday, is when those people are potentially in place to make a switch like that. And even that doesn't happen at the drop of a hat. You can't just call a different group home and send somebody across town to this group home because they don't like this group home. The patient may not always understand that. They may be super frustrated. They may be at a new group home. There's lots of things that they think they may get in the ER, which the system is not set up to do. Right? There's a thing called history alternans. It has to do with the story changing from provider to provider. So as a resident, I'd go in and talk to a patient about chest pain, and I was asking questions related to a pulmonary embolism, right? A blood clot that starts as a DVT in your leg, it goes to your lungs, could cause chest pain. And I'll ask the patients a bunch of questions. I'll go present to my staff and explain the case. They come in and talk to the patient. And I had asked the patient, did you have any swelling in your legs? No. Have you ever had a blood clot in your legs? No. The staff comes in and asks the same question. And now the patient says, oh yeah, my left leg has been really swollen recently. And I had a surgery like 3 weeks ago. And the staff looks at me like I'm a moron, right? I asked the questions, but the patient didn't think of it. Now, after more time to reflect, they thought, oh yeah, by the way, that is actually a thing, right? So patients are not necessarily malicious when they do this. They think of things differently. The part of their story, as they're sorting it out in their own head, changes as they talk about it. Like, oh wait, there is this other thing that I didn't think of, right? It changes between whoever shows up first on the call, the first responders, they get a story. EMS gets a little bit different story. The nurse at triage, or when the patient first gets rooms, gets a story. The doctor gets a different story. It changes. It's not necessarily that anybody's being malicious. It's that the patient thinks of things differently, or the things that they think are pertinent to the story change as they're talking about it. So patients often have personality disorders. Again, it makes it difficult to communicate with people who have personality disorders. There's some in particular that make communication very difficult. They often have difficult interactions in the world, and now they have difficult interactions when they interact with us. So their literacy and education in general may not be great. They're not all geniuses. We know that. Their education, their literacy, just functioning in the world may not be great. And then you add medical literacy onto that. So now you're managing a patient who doesn't get by so well in the world, just at baseline, because for any number of reasons, most often the cards that they were dealt and the choices they made, which is essentially how we all interact in the world because of what's been done to us and how we reacted to it. That's kind of a universal thing. But they're in the position that they're in, and now you add a medical problem, either a mental health problem, a medical problem that they have to deal with, right? There's lots of layers to this that make this complicated when you're not doing very well. The other thing that is frustrating about these calls is that there are no easy solutions to this. Right? The system doesn't solve these problems. As the world goes on, I feel like there's more people who have mental health issues. There's more people with chemical dependency issues. Homelessness is not going away, right? And there's no easy solutions to these. People want to say that the solution to homelessness is just build everybody a house. That doesn't solve the problem. It's been tried, it doesn't work, right? Giving mental health patients more medications, that doesn't necessarily solve the problem. Making everybody who has chemical dependency issues go to rehab doesn't solve the problem. There has to be some personal responsibility. Patients often need to want to get sober. If they're in their throes of addiction or withdrawal or actively using, it's very hard to convince them to stop, right? Everybody changes when the pain is great enough. So depending on where that person is at with all of the things they're dealing with, they may not be ready for change yet. Forcing change on people is often not successful. Now and then it is, but again, there's no easy solutions to these things, right? And we're left with trying to do the best we can with those folks, given the constraints of the system and of the world. All right, moving over here now, we have some system things. Fairview Southdale, right? So a hospital system. As an example, I'm using that because that's where we take most of our patients, to Fairview Southdale. They're representative of any of the medical systems in town, Alina, North, Hennepin. They all have similar hierarchies, as we'll talk about here, and the people involved. I don't have their org chart. This is not meant to be an exact replication of the system, but in general, think about these levels of the system. So there's the C-suite folks, the CEO, CFO, those sort of people. In the C-suite, you're going to have a chief medical officer and a chief nursing officer, right? Usually a doctor and a nurse who have risen up through the ranks of administrative things, and they make decisions broadly for the hospital. Under that, you probably have a critical care director. A system may have somebody who's a doctor who is in charge of critical care, being, let's say it's the ER and their ICU services, okay? Under that, you're going to have people in charge of the ER. In this case, you're going to have an ED nurse manager, sort of the highest level that manages, just responsible for the ER, just like you would have a nurse who's in charge of the ICU services. In parallel to that, in the ER specifically, we have a group called EPA. That's who I work for. I work in the Alina zone. Fairview Southdale is one of their zones. They staff most of the ERs in the West Metro except for West Health. They do Methodist, North, Mercy, Unity. They go all the way out to Centricare. They do Fairview Southdale. They do Ridges. So at the C-suite level, my ultimate boss contracts with the C-suite of Fairview Southdale, and EPA staffs all of the ERs. Right? So we are a separate entity. We don't work for Fairview Southdale. We don't work for any of the hospital systems. We are our standalone entity, but we contract with those systems to work in the ER. And then you have zone directors. So there's an Alina zone director, a Fairview Southdale, a Fairview, Alina, Fairview, Centricare, right? You have these different zone directors. Under that, you have an ED medical director, an assistant medical director. They would sort of be similar level of oversight with the ED nurse manager. So the medical director on the doctor side with the nurse manager on the nurse side helps make the decisions for the ER to do the best things they can and provide the best care in the ER. Right, under that, you have a charge nurse in the ER on each shift, and then you have the shift nurses, and then parallel to that, you have MDs and PAs primarily who work for EPA, right? So these black lines sort of indicate the parallel levels, right? So the C-suite, they talk to each other. At the actual managers of the ER, these work together, and then the day-to-day providers that you're going to interact with are going to be MDs and PAs, the shift nurses, and then under the mental health piece of this, which falls under Fairview Southdale, you're going to have the crisis workers, social workers, counselors, those sort of people, right? So these black lines, these are the three sort of like where the rubber meets the road, or the boots on the ground people are the docs, the nurses, and the mental health providers that are working in the ER, right? And again, on the mental health side, you have a number of mental health providers, the crisis ones, social workers, you have psychologists, they don't prescribe medications, psychiatrists do prescribe medications, you have inpatient mental health services. We all know that mental health beds are in short supply, so those resources are often limited. There's often long wait times for patients trying to get to a mental health bed. I can tell you on the night shift, we often don't have in-person providers. We have telehealth providers who talk to the patient on a Zoom call. When I work in Buffalo, when I work in Mercy, I have a telehealth provider that gets on a Zoom call with the patient to try to sort out the best thing in the middle of the night, because these people are not typically around in the middle of the night. So sometimes patients will wait around until morning to talk to a psychiatrist if they actually do need a medication adjustment. So there's various levels of care depending on when you come to the ER. Other ancillary people that fall into the Fairview Southdale bucket, you have a security director. So again, this is not their org chart, but generally speaking, you're going to have a security director for the entire hospital. You're going to have ED supervisors, shift supervisors, and then the security the boots on the ground people. I guess I could have another line drawn over here to the officers that you're dealing with in real time, right? So also falls under Fairview Southdale. You have techs, EMTs, HUCs, those are the health unit coordinators. They handle administrative responsibilities in the ER, paging people, calling specialists, answering phones, that sort of thing. The resources that Fairview Southdale has varies quite a bit, depending on if it's days or nights. During daytime hours, you essentially have all the specialists available to you. In the middle of the night, you don't have very many. Most of the specialists that come to the ER in the middle of the night are cardiologists and surgeons. All the other subspecialties don't often come in the middle of the night unless there's really a true disaster, which is typically not the patients we're dealing with. People don't often need emergency surgery in the middle of the night. Very rarely does that actually have to happen. Big trauma is sort of the exception to that. Fairview Southdale falls under EMTALA. So this was a law put in, I believe, in the 1970s, which basically makes all ERs accept all patients who come to the door, regardless of ability to pay. So it's an unfunded mandate from the government, which says every ER can't turn away people who are in active labor. You can't turn away people who actually have emergency conditions. It requires a medical screening exam, an MSE. The person that does the MSE is somebody deemed by the hospital able to do that, right? It could be nurses, it could be mid-level providers like nurse practitioners or PAs. The places that I've worked at, that decision the hospital blesses the MDs or the doctors to make the decisions about a medical screening exam, right? So we have to see everybody. I'm not a lawyer, so this is not a legal opinion at all, but EMTALA is sort of a tricky thing. It is a big deal when hospitals violate EMTALA, which they rarely do. It is a big deal because their CMS funding is tied to that. So there can be big penalties, and it could be a big deal if they actually refuse to see patients. But for example, say you have a patient who comes to the ER and they have chest pain, and they're in the ER for 3 or 4 hours. They get an entire chest pain workup. They got x-rays, EKGs, maybe a CT scan, a bunch of labs. It's deemed that they don't have an emergency medical condition. The patient maybe doesn't want to leave because they have no place to go. And they leave the ER and they call 911 from the bus stop because they didn't think they got the appropriate care. And if you look at the medical record, they certainly did get the appropriate care with 2 troponins, again, the EKG, the labs, the imaging studies. They had a complete workup. That hospital may say, no, you can't come back here, right? And do they have to? When you literally just had the patient with the same complaint coming back into the ER literally 10 minutes after they were discharged for that thing. In most cases, hospital systems are probably going to turn that patient away. I don't think that counts as an EMTALA violation in my non-lawyer opinion. But if the patient now is suicidal, so they have a brand new complaint, and again, maybe it's just because of their immediate wants and needs are not being met and it's 20 below, is the hospital required to see that patient? Maybe they trespassed the patient because they caused such a problem when they came back to triage that the hospital saying, no, we're not seeing you again, right? So what violates EMTALA? It's rare that hospitals actually violate EMTALA. So, all right, moving on to the last column here. So we're all human beings. We're all flawed. There's good and bad people in every profession, right? Hopefully more good than bad, but that's across the board. Whether you're a plumber or a doctor or a cop or a firefighter, there's people who are better and worse at their job. That's just the way it is in life, right? Specifically, and this is not an exhaustive list, but we're dealing with people in all these different pieces. So this applies to us in public safety. It applies to the EPD docs, the Fairview Southdale providers, the nurses, security, the techs, the mental health people. Depending on your education, your experience, how good you are at dealing with people, what you've seen happen before, what your attitude is about dealing with patients, your politics. This may be shocking to you, but not everybody likes the police. I know that's kind of maybe you weren't aware of that, but we're not so popular in some circles, right? Are you tired? Are you hangry? Are you bringing your personal issues to work? You had a really bad time at home and now you're on shift and you're letting it spill over because you didn't do a good job of compartmentalizing the issue that you're dealing with, right? I'm not downplaying anybody's personal issues, but again, depending on how you deal with that, it may affect your work. I think this one is a huge one. How is your communication? Can we talk this patient down? Can we talk to them about a reasonable solution? Are they in a state of mind that they can even handle a normal conversation about what the limitations of the system are, what we're able to do, what they want to have happen, what they think should happen, what we're able to provide for them? How are we at communicating? I think communication is often poor in medicine for sure. In public safety, it's poor. We use non-specific terms. As an example, a heart attack. A heart attack is very non-specific, right? Damage to your heart because your heart was running really fast from SVT and AFib may cause your troponin, which is the blood test we get to look for heart damage. That may go up. That doesn't mean that you had a heart attack in the classic sense of what people think of as a heart attack. A heart attack can mean an occlusion myocardial infarction. It can mean a STEMI, a non-STEMI. It could mean sudden cardiac death, often an electrical problem. STEMIs and OMIs are often plumbing problems. And again, those are not perfect examples, but that's not the point of this whole talk, so I'm not going to go into the weeds there. My point is that the words that we use to communicate to patients need to be as precise and concise as possible, right? We need to be very clear about what we're able to do, what they want to have happen, what they think should happen. So communication is huge throughout all of this. How much liability do you want to take on, both personally and professionally, for your organization? In general, EPA doesn't want us to talk to EMS very much when it comes to, we certainly call, EPA docs will talk to EMS when it comes to calling a cardiac arrest, or maybe like, can I give another medication for cardiac arrest? Those are calls that we will field. They specifically don't want us talking to patients when EMS is on scene and thinks the patient needs to go, and they want the doc to get on the phone and convince the patient to go. That takes on more liability for EPA. It's not something that's necessarily in our wheelhouse to do. Generally, that EMS system should be calling their medical director or talking to a doc in the ER. But again, the EPA doesn't work for Fairview Southdale. We don't have an EMS system, so that's not really our bucket to get involved with, right? Personally, how much liability do you want to take on? Right? If this is a high-risk situation, depending on what the patient's dealing with, like everybody has their level of liability and risk that they're willing to accept. And I can tell you that in every system, whether it's your fire chief, your police chief, the C-suite at any organization, less risk and less liability is probably a universal theme that everybody wants. So what are your capabilities? How good are you at your job? What can you reasonably do? What about your work ethic? Are you one that's just getting by, biding your time, and you're about to punch out and retire? You don't really want to work that hard? Are you young and a go-getter and doing the best you can? Right? We know that not everybody works the same. The timing of things, which speaks to the resource issue, which we all deal with, right? There's calls pending. There's taking somebody way across town for EMS, takes that truck out of service for a while. This patient has called now, they called 911 4 times in the same night, and there's been no resolution to this. So our resources are stretched. The ER is also dealing with that in terms of their resources. Like I said, mental health providers are typically telehealth overnight. So between the days and nights, I can tell you that there are far less resources on the night shift than the day shift. So all of those things apply to all of these entities that are when we're dealing with patients that are difficult to deal with. So trying to wrap this all up now. What do we do with all this, right? We're not solving, none of these things have simple solutions. If they did, they would have been solved, right? So my last bullet points, control yourself, right? I think it was General Schwarzkopf in his book a long time ago made the comment that he controls what's in the circle around his own 2 feet. And that's it. I tell patients that regularly when they ask about something that they think should happen. They want their surgery tonight for this thing that's been bothering them for 4 months. Like, well, I can't make a surgeon operate on you. So I control the circle that's around my own 2 feet. That's it. So control yourself, do the best you can, not bringing your personal issues to work, and treating the patient as good as possible. Being as precise and concise in our communication as possible. Running things up the chain of command when you need to get a captain involved. On the police side, when you need to call a sergeant. When you're in the ER, asking to speak to a supervisor. If you're not getting an answer, politely engaging in conversation and saying, hey, can I talk to one of the docs who saw this patient? Maybe they're there, maybe they're not. Maybe the patient was evaluated by the doc and now it's shift change, that doctor went home. There's a new doctor who knows nothing about that patient. Again, going back to like, do they want to jump on this thing that potentially is very difficult to deal with, that's going to take a lot of their time and they don't really have to, right? You can't fault that person for not wanting to get involved if they're not required to get involved, right? If the patient's not in the ER, you're not probably going to get a doctor to come out to the bus stop and talk to the patient, right? If they're not checked into the ER, it doesn't fall under the doctor's purview to deal with that. It doesn't fall under anybody's purview in the ER. So recently we had a call where there was an inpatient who got discharged from a medical issue and then had a mental health issue, right? So the inpatient doctor is a medical doctor or a hospitalist. They don't deal with the mental health side. So getting that person to make a call about a mental health problem, they're probably not going to get involved in that because that's not their area of specialty. Are you going to be able to find a mental health person who's just going to come out and deal with that? Again, when the person is not under the care of the ER or care of the inpatient side, right? Doctors and providers are not going to take on extra liability personally or professionally to talk with someone if it doesn't fall in their bucket. So it's a now and tomorrow game, both, right? We have to do the best thing for the patient right now, but we also all play in the same sandbox. So you're going to see the same nurses on shift. You're going to see the same doctors. You're going to deal with the same security officers, right? You're going to deal with the patients down the road. So doing the best thing to treat the patient well and treat the people that you're interacting with well matters, right? If you doing something expedient now that is going to harm long-term relationships is not ideal because you're going to deal with these people again. They're going to remember how poorly or disrespectfully you treated them. That's not going to serve you well, right? So it's a now game, it's a tomorrow game. We have to think of both. The patients come first. At the end of the day, as I'm wrapping up this long talk, and I hope you've stayed to listen to the whole thing, the patients come first. So that's the bottom line. And it's not, again, to go back to what I said at the beginning, it's not about you. It's really about the patients and trying to do the best we can in a system that doesn't work perfectly. So thank you for your time. Reach out if you have any questions. Thank you.